I will hand it over to Dr. Lebow.
Well, thank you. Hello, everyone. I think this is my third or fourth visit with the group, and so I want to welcome everyone. I'm starting to see familiar faces, and that's always nice. When we decided on this subject, we decided on the flu, but because of all the new everything that's breaking on the vaccines, I'll also talk about that, and of course, leave time at the end for questions. Starting out with the flu and COVID, what we're finding is that we are seeing the lowest amount of flu that we've seen in many years. We're doing testing for both COVID and we do what's called a multiplex test, which is when we test people now, we test for both for both COVID and influenza, and we're seeing very low rates of influenza. For a few weeks, it looked like it was starting, but then it sort of fizzled out. The reason people think this is true, and this is so, and it's across the country, is that the social distancing and masks happen to work better for flu than they do for COVID. So everything that we're doing is actually keeping the influenza at its lowest rate ever. The conversion rate usually at this time of year for positives is about 6% in the past. This year it's about 1%. So flu turns out not to be, because if you remember, there was supposed to be this perfect storm of flu and COVID, but it has not materialized. So with that, I think what I'd like to do, besides talking about the flu, is maybe talk about some of the vaccines that are coming out, and maybe what I think everyone needs to know in general, and what you with the cancer survivor community and the cancer community needs to know about, because there's been a lot of information that's come out just in the last couple of days, and a lot of thoughts about the vaccine and people who have had cancer. First of all, there's 3 vaccines that are close to FDA approval. The closest one is the Pfizer vaccine. The Pfizer vaccine is, as well as the Moderna, are what's called an RNA virus vaccine. Now, you're hearing a lot about this as being something very, very new, and we've never seen it before. That's not really true. The people, oncologists and people like yourselves, have been having this kind of treatment for many years. It's called for the treatment of certain solid tumors. What they do is they put the anti-tumor medicine in lipid nanoparticles so that they can enter the cell. Well, that's how cancer medication is delivered. What they're doing with the virus for the first time is using this same technology to deliver RNA to tell the cells to develop immunity. And this has never been done before, but apparently it works perfectly okay, and seems to be, after 2 injections, giving immunity close to 90% in the Pfizer and about 94% in the Moderna. And we're not really 100% sure with all the data with the new AstraZeneca, which uses a little different technology, but I don't want to get into the weeds on that. But just the take-home point, and we're going to talk a little bit about this later, so it's important to remember that it's the vaccine is in little particles that go to the cell. They are incorporated into the cell, and they are RNA that tell the cell to produce antibodies to the virus. So we've talked about the effectiveness. It looks pretty effective. They have had some side effects, and let's talk about the side effects for a second. The main side effects that they've seen so far, or the most serious, are allergic reactions. This is typical of all vaccines and just about any medication that you can think of. A medication that comes in a vial has a lot of other things, everything, and they're required by FDA. Things like preservatives. There's a little bit of silicone in a vial. There's a little bit of elements to keep it from degrading. So it's sort of a mixed bag in an injection. Most of it through the years has proved to be very non-allergic, non-allergenic. However, there are certain people who are hyperallergenic who have had some reactions. And so we're just keeping an eye on that. And people that the current recommendation is people who have a history of severe allergies probably should take the vaccine in a hospital where they can have the allergic reaction treated. The other side effects are just what you'd expect from the flu vaccine. The flu vaccine, unless it's a big change from year to year, usually doesn't cause many symptoms. But when it does, it causes achiness, a low-grade fever, and things like that. And we're seeing that with the virus as well. So there are some side effects, but they're considered minor. The effectiveness of these vaccines is high, as I've said, 90% to 94% after 2 injections. All 3 so far of the top 3 that are closest, Pfizer being already very close to FDA approval. It's been already approved by the committee and is going to the full FDA, and that could happen today or tomorrow, or certainly probably by Monday. And then the others they're all 2 injections. The Pfizer is 1 injection, and then the second injection 22 days later, and the Moderna is 29 days later. The advantages of the Moderna and the AstraZeneca is they don't require as much refrigeration, although they all have handling precautions and will require a lot of refrigeration and freezing before they're given. And that's a problem in getting it into certain communities and certain places that don't have access to this sort of freezing equipment. Besides the side effects, and let's move on to who is going to get the virus. Right now, it's pretty unclear. What's clear is the recommendations from the FDA is that the virus go to those most at risk, which they've identified as people in nursing homes or who work in nursing homes, and healthcare providers who are on the front lines. And that's going to be everyone from EMTs to ER doctors to ER nurses to people who, and I can tell you, people often don't realize this. The people often at the most risk in a highly infectious environment are housekeeping, and the people are cleaning up between patients, and they should get their viruses as well. After that, it's unclear how and who will get the virus. We do know that the viruses so far are going to hospitals, number 1. Number 2 is they're going to CVS and one of the other large pharmacy companies. And then we, as urgent care, we have 5 urgent care centers in Los Angeles. We've applied to the state of California to be a vaccine provider. although we don't know when we're going to get those. We do know that there's a lot of reporting requirements, but we've still gone ahead and applied. We don't know what's going to happen. Now, let's talk a little bit about so I think the way to think about this in a general way is that the end of the tunnel is visible. However, it's going to take months to vaccinate millions of people, tens of millions of people. And in fact, to really stop the virus, the estimate is that you need to have immunity either by acquiring the illness, which several million people have already done that, or through vaccines, anywhere from 70 to 80% of the population. Now, to get there, that is a long stretch, and that's going to take I've heard things like months and everything. I'd be surprised if they're done by the summer. I would expect that it will be through the fall for everyone who is eligible to get their vaccine. However, by next year, this time, we probably will not be worried too much about COVID. And so taking a very long view, everything is pretty good. Now let's talk about, there's been a number of articles and a number of hypotheses, because there's no studies on what I'm going to be talking about the vaccine in people who have had tumors, hard tumors primarily, tumors of the organs, and have been treated with a chemotherapy before or other treatments. Here's the issue that has come up. And it's theoretical at this point, and so I'm going to have two recommendations when I finish this, but I do want to go over this with the group. As I've talked before, the way that the vaccine works is very similar to how chemotherapy for certain tumors works. That's where they got the idea. That's where this all came from. The reason that some of the chemotherapeutic agents work so well is that the little particles that the little envelopes of lipids that they put the medication into that are preferentially taken up by cancer cells, because cancer cells have sometimes less thick cell wall, or they have less, they're just taken up more by the cancer cells preferentially. However, they're taken up by all cells, but they prefer, and the theory is that they prefer the cancer cells. The issue that's been brought up, and this, like I say, the first article just came out on December 2nd, so we're at just a week ago, is that, well, are these nanoparticles going to be that are supposed to help the body express immunity, are they going to be taken up preferentially by the cancer cells, and therefore the person who's given the injection, all the vaccine will go into the cancer cells, which is how this technology began, and they won't get a sufficient dose into their normal cells to produce a antibody reaction. So far, that's what people are saying, and at the end of these articles, they're saying more work needs to be done. I think at this point, it's a theoretic discussion about a concept about how the vaccine will work. We don't know yet. And my recommendations would be that, and unless your doctor, to discuss this with your doctor, I think that your doctors will probably tell you to go ahead and take the virus, the the injection, take the vaccine, because the risks of COVID are so high, and there's not a bad outcome if some of the medication get into the cancer cells. Is more of a non-outcome. It's not something bad will happen. It's just something good might not happen. But so I think that from a risk benefit ratio, you should, it's still, nobody has said that cancer patients are anything but high risk. The reason the reason they're distributing the vaccine to nursing homes is because they've identified nursing homes as high risk. But people with pre-existing health problems such as diabetes and cancer and heart disease are also high risk. And what my recommendations to you is to have a discussion with your doctor, number one. The second person that and I learned this from my wife, and it's a good idea to know your local pharmacist, the pharmacist at your local CVS. Many of us go in there to get medications from time to time, and they ask, would you like to speak with the pharmacist? I would take advantage of those opportunities at every time you're offered, every time you fill a prescription. Get to know your local pharmacist so that they know you and they know you're a high risk patient, and let them know, hey, I'm here when the word goes out, because I don't know that they have. Don't assume that everything is going to be as 100% organized as we might like. And it might be that they're given a instruction, okay, these viruses are supposed to go to healthcare providers and those most at risk. Well, you're most at risk. So I think as long as your doctor checks off on it, I would go ahead and let your pharmacist know the next time you're in or something, hey, I'm high risk, and when you get the vaccine, I'm here, let me know. So that's sort of, I think that's where we are with the vaccines now in the US. Other than those who have been getting it experimentally, nobody's really in the general public gotten it so far. And there are thoughts, there's one more thought, and even some healthcare providers say this. I was on a conference call with some other doctors the other day, and they said, well, I would like to be I want to get my vaccine early. I want to be in the second million. They didn't want to be in the first million because they wanted to make sure that there was no widespread issues or anything. So, that's why I'm saying to talk to your doctor. Let your doctor know that you are interested in the virus, in the vaccine. And by the way, the people who have had COVID already are supposed to still get the vaccine. So that's one of the common questions, since so many people have had COVID. So I think that is sort of the prepared part of what I wanted to talk about. Are there any questions or any other things that you'd like me to talk about today?
Thank you. That was great. I have a
It's
question.
a lot. I know it's like a fire. I feel this way too. The information is coming so fast. It's like trying to drink out of a fire hose. But, please just shoot away if you have any questions, or if there's a subject that you'd like for me to talk about besides the flu and besides the vaccines, or anything on testing.
I have a question from one of our users. She asked if we would ask this on her behalf. And she says that her son was just diagnosed with cancer. And he also has had Guillain-Barre syndrome.
Correct.
So he's not supposed to get the flu shot. So what would be your recommendation in that?
Well, I would again, there are the Guillain-Barre is it's a uncommon but not rare uh, illness, and it does cause muscle weakness, and it has been associated with some vaccines. So the you would need to talk to your it's one of the few illnesses, not so much the cancer, but the Guillain-Barre, that you may want to talk to your doctor. And I'm not sure what the recommendations for this particular vaccine is, but people who've had a history of Guillain-Barre generally have to be very careful about taking vaccines. So this would be the one time when I would say, hold on, and I'll probably need to be more educated myself about that, because it's listed, but I don't know the true details and at the granular level. But I would just say, talk to your doctor before getting the vaccine. They may recommend that you don't. And look, none of us are going to get the vaccine right away. And many people will not get the vaccine for months and months. So COVID is still here. We're still in the midst of a COVID up spike, and COVID is going to be with us probably until the spring or the fall. So we really need or the spring or the summer. So we really need to continue what we're doing, which is social distancing and wearing masks and doing those sort of things. And I'm sure that the person's, the questioner's son's physician has recommended that they do all those things, to be extra careful.
Thank you.
My question was, when are you going to take the vaccine, and which one would you take?
Well, I'm gonna take. We should be able to get a hold of the Pfizer. We think the Pfizer. I think the Pfizer has already been delivered to our local pharmacy. That's what we've heard, and I probably, because I'm sort of a frontline person. I do a lot of administration now and some telemedicine, but as an older person myself, I'm not in the front lines that much. So I want to make sure that my staff all get it, but I'll probably get it along with my staff, which in an urgent care center, the people that I work with through the ERs are getting it through their hospital. The urgent care people will have to get it through the pharmacy or will be distributed. So I'm guessing that I probably won't get the virus until maybe the middle of January or something like that. I will take whichever they have. I would like to get back to a normal life, just like everybody else. So if the Pfizer is available, I'll take that. The Moderna is very close, and then the AstraZeneca, which was developed in Britain and wasn't part of the American effort, but seems to be very good. That seems to be a really good virus, and that's one that we may end up giving because it doesn't require all that sub-zero minus 80 degree storage. So, as small clinics, we will not be able to get our hands on that kind of equipment, but we might be able to get our hands on the equipment to store the AstraZeneca vaccine. But I'll take it when it's available, and I'm guessing it's going to be probably mid-January, late January when I'll get it.
So thank you. So I am in remission with leukemia. I've had it since 2008, but I still take Gleevec, my medicine every day. Um, so I also have MAC in my lungs. So and as you can hear, I get sick quite often. So am I a good candidate to tell my doctor, you know what? I mean, he knows, like a lot, but am I on the first line? Like, should I be on the first line?
Yes, and I really, yes, because you're high risk. COVID would be not, it would be it's very difficult for people with pre-existing lung problems or immune issues. He recommends you take the flu vaccine every year, right?
Yes,
It's
yes.
the same thing. I don't see any reason, and there's no arguments. Anything that they've talked about is theoretic, and certainly the advantages of getting of having immunity, and even those people who don't get full immunity who have gotten COVID after they've been vaccinated, none of them have required hospitalization. It's been very mild, very manageable. What it does is it blunts that immune response in week 2. The people who get really sick, there's a few people that get sick like there are from the flu. We every year, 50,000 to 100,000 people die of the flu. It won't be this year because the flu is not very prevalent, but the people that die, they generally will be in two classes. One, they have such severe lung problems that even a little added flu is just too much, and they have a problem right from day one. Or it's those people who initially have the flu, but they get sick in the second week, and they end up with serious other infections and things like that. So what it's doing is it's blunting that reaction in the second week, and that's where most of the people in the hospitals are. That they're with that severe reaction to COVID. So the viruses blunt that and make COVID more like a regular flu than this very difficult beast of a flu, but my recommendations: you are high risk, you should be first in line or right with the nursing homes and everybody else, high risk patients. And that's my message for today.
Thank you very much.
Sure.
I have another question on behalf of a user or one of the community members. She says that for someone who's Opdivo, should they take the vaccine even if they have melanoma in their lymph nodes?
Yes, like I'm saying, I think that if the rule of thumb is if you can take the flu shot, you should take the COVID vaccine shot. And unless your doctor comes out with some particular reason, generally speaking, everybody should be, you would be considered high risk. There's a tendency to don't anyone, because you're sick, devalue yourself as being worthy or eligible to be first in line, because you're at risk. And that is when you read the recommendations from the committees, it's to get people at the highest risk first. And that would include you on this call. And that's that's one of my other messages today is you're at high risk, get the vaccine, talk to your doctor, talk to your pharmacist. I wish I knew more about how it would be organized. How are we going to identify? We can identify people in the nursing homes because that's where they are. We know where to find them, and we can identify high risk healthcare providers because they're at the hospital, in the ICU, or in their, but how are they going to identify everybody else? How is that going to happen? What is that process? And what what I would say today is, don't be passive about it. Be your own advocate about it. Talk to your doctor, let them know I'm interested in the vaccine because I want to get back to normal. I want to lead my life. I want my life back. And the quality of life that of living inside and not seeing family as much as you could, that's not, that's not good for anybody. And so I would just, let your doctor know I want the vaccine. Let your, get to know your pharmacist, because that's where the vaccine is going to be early on, in the pharmacies, at least in California. Now they may have, there's different states are doing it differently. And I would go, everybody, that's another thing, that it's often hard to get through some of the websites. There's the national FDA where you can find a lot about the vaccine, but I would Google something like, if you're in, let's say, Minnesota, vaccine distribution, Minnesota, and see what the current plans are in your state. In California, it's not well formed, and I think they're getting their information from the FDA, and I just don't think the delivery system is worked out exactly right. And it's surprising because you'd think it would be by now. You'd think that the delivery, but we'll see. I mean, the hospitals, it's worked out, and for nursing homes, it's worked out. But what about everybody else who's out in the community? How is that going to work?
Yeah. Thank you. And then I'm assuming the same goes for someone who's currently on chemotherapy or is neutropenic.
Neutropenic should not affect it at all. Now, whether you're on chemotherapy, that's where I get back to to why I talked about the mechanism of how it works. And that's why to this group I spent a little bit more detail in explaining how the vaccine works. It works very similar to chemotherapy, or certain forms of chemotherapy, not all chemotherapy. So I would talk to my doctor. If you're currently actually, on a chemotherapy regimen, I would talk to your doctor. I still think that, all things being equal, if you got a flu shot, you probably ought to take this. However, based on the mechanism of injury, or the mechanism of action, I might talk to my doctor just to make sure, because they also don't want a chemotherapy agent to be competing to get into a cell with the nanoparticles of the virus, of the vaccine. So, but once again, no one has any studies about this. Nobody has anything but this theoretic construct that we've come up with, that the vaccine may be taken up preferentially by solid tumor cells, but we don't know that 100%. And so if you're actually getting chemotherapy, I think I would talk to my doctor about it, but you should do that. You don't have to do it this week, but the next time you see your doctor, or in the next 2 weeks, I think they'll be done with the healthcare providers and the nursing homes probably in 2 or 3 weeks, or by the new year or so. So sometime before the end of 2020, and thank goodness 2020 is over, but sometime before 2020, talk to your doctor, or the next time you're with your doctor, or the next time you're getting treatment, ask them about what their recommendations are for and it might be that they're going to say something like, let's do the AstraZeneca. The Moderna and the Pfizer work with this RNA that I talked about. The AstraZeneca has a slightly different, although they may at the end of the day they do the same thing, but it has a slightly different mechanism of injury. I keep saying mechanism of action. So they may say, well, I would prefer that you get this vaccine rather than that vaccine or something like that. But this is for a very limited number of people. For in general, I would still say talk to your doctor, let them know you're interested in the vaccine, get to know your pharmacist so they know where you are, those sort of things. I think you're muted, unless I'm muted.
My apologies. Is there information on how long the vaccine is going to be effective?
No, there isn't. We do. This is what we know so far. For innate immunity that comes from having the illness, we know for sure that immunity lasts at least 90 days. Now, there's certain people that have gotten reinfected with COVID after 90 days. It's a rare occurrence. We would say there aren't anybody that, but we've only had COVID with us since earlier in the year. So we don't really know much. We only know a little bit from these few people who have seemed to have gotten it again. It may be some of them are testing errors. I know that for sure. That some people, none of our tests are 100%. So it might be that somebody tested initially positive, and then they're negative, and then 4 months later they tested positive again. They're not really very sick, or maybe they have just a regular cold, and that made them get tested, and they were positive, and then they're saying, "Well, you looks like you've got COVID again." And I'm not 100% convinced. However, it may be, we don't know for sure whether this vaccine is going to be like a measles and mumps vaccine that you take once or twice in your life, or is it going to be like the flu vaccine that you take every year? So we don't know exactly. I think at this point, I would sort of, I think that we're probably going to be looking at requiring vaccinations on some sort of regular cycle. A tetanus shot we give every 5 to 10 years, a flu shot we give every year, and a measles shot we give once in a lifetime. So it's going to be one of those three, but we don't know which one.
So one of the things, when I get the flu shot, I always get the flu for like 3 days. So would that be similar?
Yes, people are getting exactly that side effect. In fact, it was when they do studies, they try to make sure that people don't know, because what they do is they give 50% of the people the flu shot or the COVID vaccine and 50% not, and then they ask them, did you get the flu? They ask them 6 weeks later, so what's your status? Did you ever get the flu or not? What's happened is in some of these, and it's been one of the criticisms of the studies, is that a lot of people knew they got the vaccine because they got achy, they got a low-grade fever, they got flu-like symptoms. Because remember, the COVID is the flu. It's a form of the flu. There are certain COVID flus that people get that are not the COVID, this COVID-19 that we're calling this year. There are other COVIDs out there that none of them have proved to be as dangerous as this, but there are other ones out there. So I forgot where I was going with it. But anyway, the COVID vaccine, I forget the question now. Where were we?
Well, it was just, I always get the flu.
Oh, yes, the symptoms. Okay. Oh, I was going to say something else about this. The symptoms, yes, you will get symptoms. So on the AstraZeneca study, what they did is they gave 50% the COVID virus, but they gave the other 50% a cold-like virus. So everybody got a little bit of what you're describing, a couple days of achiness, a couple days of low-grade fever in some, a couple of days of being fatigued. And that way they didn't know whether they had the flu virus, a flu virus or a flu vaccine or a COVID vaccine. The other thing that's different about AstraZeneca, on the Pfizer and Moderna vaccines, the way they determined its effectiveness was to ask patients, did you get COVID? They asked them 6 and 8 weeks later, somewhere in that, did you get COVID? And they saw that 95 for the Pfizer, and this was a very large group, tens of thousands of patients. But at the end of the day, the numbers are still sort of small. What happened when they looked at the two different groups, 90 patients of the group that got the placebo got COVID, and only 5 of the COVID vaccine patients got COVID. Now, none of those 95 individuals ended up in the hospital. Nobody got really sick. And they think that the 5 who got it, who were vaccinated and still got COVID, either had COVID before it started and it was already in their body, or they got it, but it was very mild case. So 90 versus 5. So they say, so that is about how they came out with their effectiveness. AstraZeneca is doing it a little differently. They're actually doing nasal swabs to see how many people are actually at a certain time period are actually have COVID at that point. Have they had, or was it effective at limiting COVID infection? Because there is a thought that the vaccines aren't quite as effective as they say. However, what they are very effective at is making sure that if you do get COVID, you get a very minor case. It's almost the same thing. It's at the end of the day, what are we worried about COVID? We're not worried about that. We're not social distancing because we're afraid to get a sneeze and a cough and feeling achy for a few days. That's the flu. We're worried about getting in the hospital and getting on a ventilator and those sort of things. For that, we can say it's almost 100% effective at keeping people out of the hospital. So that's why, some of these numbers can be misleading. What we really want to know is it blunting the danger of COVID? And that it's doing a great job at that. So that was sort of a long-winded answer.
But that was great, thank you. And I guess just for my own personal self, you can hear how I sound sometimes, so it's been 4 weeks already. I've been on a Z-Pack. I've been on, steroids, a med pack, and now I'm on Ceftonir. So very often in the January, February, I get like pneumonia. And it stays at the bottom of my lung because I have so much scar tissue in the middle. So is there anything else you might recommend? Because I would really like to feel better.
I don't want to, I think that it sounds like your doctor has a good handle on this and getting you through these things. I think my message is just to make sure that, you're at a high risk and you ought to be very high on the list of people who get the COVID vaccine. And, I don't know how how doctors, what role they're going to play early on, you know, how are they going to make appointments at initially at CVS for people to get the vaccine? I don't know. I wish I knew more about that, and I wish it was better published so I could tell people, because I get asked that. But what you want to do, I can't offer any ideas about your the pneumonia. However, what we want to make sure is 100% you're not getting COVID. So
Right.
you should be getting the vaccine, and, you know, talk to your doctor about it to make sure that they know that you want to get it and that you want to get it so you can resume your normal life.
Well, and just to add, I know I've spoken to him, and I have actually spoken to someone at the CVS where I live. So it's about $10,000 to get a freezer, you know, for, you know, keeping COVID. And, you know, with his practice or anybody's practice, you know, that's a lot of money. And I'm hoping that they're going to be able to do it. Otherwise, how will we get it?
It's going to, right. This is a huge problem. That's why, you know, the Moderna does not, it requires temperatures that are more in the commercial freezer range. And the AstraZeneca does not require, I'm looking at my notes because you know, nobody can keep all this in their head. The AstraZeneca does not require as much, you know, that will not be a huge problem as far as storage, but they're off for a while. But this is a big problem. So most of the flu virus initially is going to go through the pharmacy system. As I said, we've applied to be a provider, but we work with one of the large county agencies, and they're is it the streets or the gas company? I forget which one we talked to, but they're buying their own freezer for their employees, and they want us to come out and do the injections. And we do that for flu every year. We have a bunch of clients that we go out to the work site and give the flu vaccine, and we're going to do that. But the flu we keep in our refrigerator. We have a special medical refrigerator. That's not going to be good enough for Pfizer. It's probably not going to be good enough for Moderna. It will be good enough for AstraZeneca. But those things you see, hopefully the other vaccines will go through a little quicker than the Pfizer. The Pfizer is still not, at least when I got on the call, it had not been officially approved. It was approved by the recommendation committee, but it hadn't been through yet. But hopefully those other vaccines will come quicker. They're easier to give to large amounts of people, because I just don't see it how you're going to have to get immunity. You're going to have, let's say the low number, 70%. 70% of 350 million is, you know, 250 million, something like that. Well, how big is a freezer got to be to have that many, or how many freezers do you need? It's just not going to be practical. So right now, the Pfizer is probably going to have fairly limited distribution, but maybe I'm wrong. Maybe the government will make millions of freezers and then everybody will be happy. But it's going to be difficult. So you're doing what I'm recommending and what I'm doing, which is, you know, keeping an eye on what's going on and making sure I'm in touch with my pharmacist to know when the vaccines are in, what they're going to do, or they may start taking appointments. You know, that's one of the things I've heard, that they're going to have every 10-minute appointments, but still there's so many people, it would still go on for months to get everyone in the community. So we want to make sure that people at the highest risk get in line fairly early.
Thank you.
Thanks, Dr. Lebow. I have one other question, and then we'll give another chance to ask more questions. So even for someone who has already had COVID, and they are high risk, do you think they will remain a priority in getting the virus, the vaccine?
I don't know. I do know this, that they are saying, as I mentioned before, that if you've had COVID, they still want you to get the COVID vaccine. I think the reason is that they want everybody at the same level of immunity. There's some people who have had COVID that you can't even find any antibodies. That means that when you have what we test for when we're doing COVID tests is we're testing for either the antigen or parts of the virus. But and that answers the question, is a person currently infected? But there's another question that we ask sometimes out further, which is, has the patient had the virus? And the way we test that is through antibodies. It's called an IgM antibody, and we have a test for that. And we say, are you positive or negative? That's done through the blood. That's a blood test. All the others are nasal swabs. And that tells you how much immunity. And the problem is that people who've gotten COVID, some people have gotten very minor cases, so much that you cannot measure their immunity. And they're probably still immune to, they'll probably never get a severe case of COVID because they have a little bit of immunity, but it's below what we can measure. So what they're saying is, let's get everybody, let's just get everybody on the same plane with the same amount of immunity, with the same dosage and everything like that. So I think that they'll probably, I don't know if there'll be a questionnaire or how they would do that. I think that you're at lower risk of COVID than a lot of people, but I would talk to your doctor. If you've already had COVID, you're at least probably covered for the next few months. You'll need to get a virus sometime, and if you've already had it, it's probably less of an immediate need. However, you are going to need to get tested or get the vaccine.
Thank you. So this has been incredibly helpful. Thank you so much for being so generous with your time. Does anyone have any final questions before we wrap up?
Hi there.
Hello.
I don't think my video.
Hello. Oh,
Hi.
there you are. Hi.
And my apologies. I had to join late because I was on another call that ran late. So this may have already been answered. But I was wondering, is there any preference between the three leading ones right now? Is there any preference between them, especially for me, I live in Canada, so it's a bit different as well. But I finished my chemo for breast cancer at the end of July. So I'm already 5 months out. My immune system's probably okay again. But is there any preference? Like, if I am able to have a choice between the three, is there one that would be preferable to take?
I don't think I don't think that we know any preference yet. You would be considered high risk. You should get the virus. My recommendations is get the virus, when it's available in your area. As far as, I think they have different mechanisms of action. Nobody has said one is preferable to the other yet. Basically, there isn't enough virus around yet, and there hasn't been a head-to-head study. Nobody knows, and we know that Moderna and Pfizer are the two closest, with Pfizer already being virtually approved.
It's
and
approved
got
in
all,
Canada already.
yeah, and right, in Canada and Britain. And it has so many storage problems, though. I don't think it's going to be the answer for large millions of people. It's just too hard to store and so forth. Moderna is a little easier. The AstraZeneca, it has a slightly different mechanism of action, although a lot of it's, it's similar. It goes into the cells. Instead of messenger RNA, it goes into the nucleus and tells the cell to make its own messenger RNA. Now, whether that's makes any difference or not, I don't know. But I don't think that I think we'll know more later, but there isn't enough information to answer that at this point.
Okay, thank you.
Oh, no problem. Anyone else? Well, I want to thank everybody. Yeah, it's 10. I better go to my next, but I want to thank everybody, and you can always email me, or you can email Olivia. Most of you know Olivia Lebow, who I'm related to. And you can always send her an email, or anyone in the organization an email if you have a question, and I'll try to answer it. So anything I can do. And then what we'll probably do is meet again when there's some new developments or just an occasional update. So thank you, everyone, and I'll see you the next time.
Thank you so much.
Bye-bye.